With me is Mick Power. He is a clinical psychologist, researcher, and writer who has worked at universities and hospitals in London, Milan, Edinburgh, Beijing, and Lisbon. He is calling us today from Singapore, where he is now Director of Clinical Psychology Programs at the National University of Singapore. He is also author of numerous books, including his latest, Understanding Happiness, a critical review of positive psychology. Thanks for having us, Mick.
Thank you.
Yes. I was introduced to your work through your book Cognition and Emotion, which is now out in its third edition. And you've written a lot about the meeting points between thought and feeling and its implications for mental health. And in terms of psychotherapy, you're most associated with cognitive behavior therapy, although you have been critical in the past of the way that particular model usually thinks and feels about emotions.
Yes,
And
that's right.
I would be very curious to know how it started for you before we get into that. So was it an early decision to become a psychotherapist or a little gradual one?
Well, originally I trained actually as an experimental psychologist. My PhD is actually in the topic of psycholinguistics. But when I was doing it, I was interested in psycholinguistics, but I didn't feel that psycholinguistics would keep me fascinated for all of my life. And it was one of those, crucial times where you start thinking, well, what things really energize you and could inspire you for at least much of your life? And it was really the sort of, I think at that stage, the clinical questions that, linking both the theory from cognitive science that I'd, been brought up in and trained in my first degree and my PhD, and then thinking that there are great implications for clinical practice, which at the time I didn't feel were actually being understood by clinicians or those who had just come up in a clinical tradition. So it was a sort of an attempt to bring cognitive science lessons into clinical practice and to improve some of the models that we use in clinical practice, as clinical psychologists.
Yeah.
And so one of the key areas that I thought was lacking, spoken about by everybody, but it felt like there was no good theory of emotion being used in clinical practice, that we had a folk psychology approach to emotion. There were things called anxiety or depression or obsessions or something like that. But these things just sort of, existed on their own in a very atheoretical way. And the sort of development of theories was all around the cognitive part of the theory, like in cognitive therapy and cognitive behavior therapies. And the emotions were just there as givens. There is just anxiety or there is just depression. And it felt like a great sort of lack of thought or lack of exploration of surely we need a good theory of emotion and not just a good theory of cognition as well.
Yeah, it's interesting because you're reminding me, I remember reading an interview by Leslie Greenberg where he had exactly the same thing to say, that it's incredible that we have researched so much cognition, but there's basically no good theory of emotion. But it's interesting that, do you remember in that particular time when you were getting started, you were particularly influenced by a book or author at that time?
This is when I was moving from experimental psychology into clinical psychology. Well, I think like many people, I was intrigued by the work of Beck, Aaron Beck, for example, and its sort of clinical implications. But at the same time, I was somewhat taken aback by the weak theoretical basis for cognitive therapy. So one of my sort of early papers was actually a criticism of the underlying theories, of cognitive therapy and related approaches, and trying to show how cognitive science could bring in something like multi-level models into clinical psychology. And that if you brought in a multi-level model, this is long before, I came up with the SPARS model, but if you brought in a multi-level model, there seemed to be tremendous implications for how we worked clinically with people, how we understood for example, as in the 𝗔𝗍𝗲 model, you have a high-level schematic or effortful level, and then you have a much lower level automatic or associative processing level. And, much of the conflicts and problems that people bring to you clinically are about the sort of, the issues between those two levels, often acting against each other, or, one level really not understanding the other level, or being surprised in some sort of way. And these sorts of issues didn't seem to be, theoretically, sort of present in the Beck type model, which is still, the sort of most dominant approach for many clinical psychologists. But I suppose I looked at it and, read, Beck's work and was intrigued by it, while at the same time interested in bringing in a deeper theoretical understanding, which in turn then had further clinical implications for how you work clinically, I think, with people. When you bring in a different model.
So let me see if I get this right, because for people who don't know about your 𝗔𝗲𝗅 model, so you created a cognitive model, multi-level one, cognitive and emotion model, to try to fill this gap of emotion theory.
That's right.
This comes also from your interest, I imagine, of research that you had done before, that you felt maybe that cognitive therapy was too clinically based and not enough experimentally based?
That's right, And I have to say that I have to give credit to my then PhD student and now colleague 𝗔𝗹𝗲𝗅, that he was one of those very bright and able PhD students who pushed me at every opportunity and forced me to think through the issues very clearly. And out of that sort of very productive, supervision experience, there emerged the 𝗔𝗍𝗅 model. So it was really very much a joint work where I was bringing in my knowledge, both of clinical and of cognitive science, and Tim was bringing both of those in as well. And the model emerged really from long work and discussions and late nights and everything with Tim. So it was a real 50-50 effort, to develop the model as it now stands. But yes, as you say, it was an attempt to bring in some better, theoretical understandings of what was known about normal emotions into our clinical understanding. Because the two fields, the clinical approach to emotions and the normal approach to emotions, they really, developed quite separately. There were separate models and theories and approaches and, techniques and so on. There really was very little addressing between the two, different areas, really, of normal and abnormal, as it was in those days.
So interestingly, it was the cognitive therapy. Is it okay to say that it was a little top-down in terms of research? In the sense,
sorry, could you say that again? I couldn't hear.
No problem. Would you consider it possible to say that cognitive therapy was researched from a top-down level?
Well, I think cognitive therapy was primarily developed by a clinician in the clinic. And then I think, that was Beck's approach. He very much came in as a clinician, I think. And its appeal is because of its considerable clinical foundations. It had application, there was never a development without it having some way of working in the clinic. But I think subsequently a number of us have brought in additional theoretical developments that have strengthened cognitive therapy. I'm not sure what Aaron Beck thinks of that, whether he sees it as strengthening or whether sometimes he felt criticized by it. But the motivation really was to strengthen it in many ways, particularly in our case to strengthen the understanding of emotion. And to bring in, as you call it, some of that top-down thinking from the laboratory, I suppose, and from theories of normal emotion into the more clinically based developments that have been made in cognitive therapy up to that point.
So, picking up where you're talking, it's culturally widespread, this dichotomous distinction between reason and emotion. And you've written a lot about this, and I would like to ask you, can you tell us how this insistence on rationality at the expense of emotion could turn out to be quite irrational?
Yes. Well, you have to blame the ancient Greeks, I'm afraid, who wanted to separate, the separation of emotion and the passions from reason and rationality. And unfortunately, in Western cultures anyway, it's been part of this terrible split. The second terrible split became from Descartes with the mind and the body. Mm-hmm. So when you add these sort of 2x2 splits of reason and emotion, mind and body, Western cultures have really got a lot of hard work to do to put those bits back together again into a much more holistic sort of framework, which in Asian cultures, you don't have those sort of same sorts of splittings in that sort of way. So now I'm based in Singapore, working in a much more Asian context. And there is a sort of surprise at our Western tradition of splitting reason and emotion, or, the male-female mind-body sort of stuff, because it seems to be Western men who thought that rationality was good for them and emotion was what women and other animals did. I'm sort of misquoting from Darwin, when I say that was his sort of approach to emotion. But I think that's been such a terrible legacy in Western cultures because, as you know, from the functionalist approach to emotions, which goes back to a much better Greek philosopher, Aristotle, rather than Plato. The functional approach tells us that just like with pain, which has an important function in our lives, and if we lived a life without pain, we die at a young age because, we learn to avoid things that are painful or manage things more carefully or take account of pain. So pain has a clear function, even though we don't always like it or enjoy the experience, but it's functional. And so the emotions, the so-called negative emotions, anger, has a function in our lives. Righteous anger, justice, and so on, these sorts of principles are often based on the functional use of anger. Or anxiety is another commonly used example, that without anxiety, we'd fall over the edge of cliffs, we'd walk in front of buses, and die very quickly if we didn't experience, the protective aspects of anxiety. Or no students would ever do very well in their exams because they wouldn't feel anxious enough to stop going out, enjoying themselves in Lisbon. And they would just, so anxiety has that function. Oh dear, I've got an exam coming up next week. I better stay in this weekend and work hard. And so it's that functional aspect of emotions which bizarrely was ignored for some thousands of years, particularly in Western cultures. And I think it's now, there's a whole, emotion movement that's putting the function of emotions back in place, that recognizes the function and recognizes that, yes, they can also be dysfunctional when you have too much of an emotion or too little of an emotion. So too much rationality can be that's not based well in emotions is dysfunctional, and people without that guiding aspect of emotions actually find rationality is insufficient, in their lives. So yes, I think it's about putting emotion back into its proper place really, as part of a healthy functioning individual, in a social context.
In the last 20, 30 years, you and your colleagues and people like Leslie Greenberg have repeatedly talked about the adaptive value of some primary emotions. And it was very interesting for me to read some of your books about how every emotion, having too much or too little, could be related with psychopathology in a way. Even an emotion like joy too much of it is probably mania. So I would like to ask you to do a bridge between this and your latest book, Understanding Happiness.
Yes.
And I would like to ask you, what misconceptions on so-called happiness did you hope to address with this book?
Well, I think the problem with happiness is that it means too many things, certainly in English. And my understanding is it has multiple meanings in Portuguese as well, for example. And a very sort of simple and pedantic point made at the beginning of the book on happiness is that happiness should really only be used as a word to refer to a short-term emotion that maybe comes and goes in a matter of seconds or minutes. But we confuse it with a very different state, which is something along the lines of, life satisfaction or an ultimate goal in life, to pursue something called happiness. And the confusion between these two very different uses, I think, leads a lot of people astray to think that happiness means like turning that state of joy into a permanent state, which is simply impossible, and it ignores the functions of the other emotions and so on, which we all need to experience as well. So the book starts off saying we should really get rid of the word happiness almost. Because it's too many uses and it's too confusing in that sort of way, other than a very specific brief emotion state. But when people are looking at more lifelong issues or something, then, life satisfaction, well-being, quality of life, those sorts of terms have a much richer and more complex meaning. So it's to sort of say, let's use those instead. Now, obviously, the people who do surveys on happiness, like, the happiness surveys around the world that are carried out, which just ask, whole nations, are you happy and how happy are you? They won't be very pleased, let's say, with that sort of suggestion, because it sort of rather undermines their research. But I think their questions are so ambiguous. How happy are you, right? Does that refer to the feeling of joy right now, or does it refer to the feeling of more general life satisfaction? And I think the misunderstanding of that in happiness surveys has led to many problems in interpreting comparisons, for example, between different countries. In terms of, Denmark is happier than Portugal or something like that. Well, hang on a minute. Maybe it's just a different translation into Danish than into Portuguese, for the happiness question. What you really need is a more sophisticated set of questions if you're trying to get at either positive affect, like experienced yesterday, or you're trying to get at more general life satisfaction, quality of life type issues.
I know that you were involved with measures for quality of life. Is that true?
That's right, yes. For the past more than 20 years, I've worked with the World Health Organization, and I've been part of a group that's developed the World Health Organization's measure of quality of life, the 𝗔𝗋𝗄, and we've adapted it and produced various additional modules for older adults, for people with disability, and other uses of it as well. So yes, I've had a long-standing interest in developing one of these more multidimensional measures of so-called happiness, which, so quality of life includes a dimension of happiness, as it were, your positive feelings, but it includes many, many more things as well to do with your personal environment, your social relationships, the quality of your work experience, your psychological functioning, your physical functioning. And so all of those sort of come together to produce this much more complex sense of quality of life. But yes, that's been another one of my areas of long-standing work now, and which I'm still continuing and involved in.
And maybe linked to this, mindfulness has become a very hot topic in psychology and psychotherapy. And there have been many models of that, like the mindfulness-based cognitive therapy and acceptance and commitment therapy. And sometimes, personally, I felt that this could have gains, but also some dangers associated with what you've written about the positive psychology movement. Like, it's a little weird for me how popular, and I'm very curious about your take of what do you think we've gained and what are the dangers from this new craze of mindfulness?
Yeah, I think you're right to put it in the context of positive psychology, because that sort of somehow, as it were, adds to its craze and its popularity. I don't tend to use mindfulness training with my own clients myself, but I'm very happy if they go to someone who's much more convinced of its usefulness than I am. Because I always like people to be, convinced by their teachers, that the teachers believe what they're teaching. I have a sort of question mark over it, that it is, it's an ancient religious technique used particularly, in Eastern religious practices. And for me, it sort of can bring in some religious views or approaches by the back door into psychology, which, and I know some of the practitioners of mindfulness, people like 𝗔𝗹𝗲𝘅, Mark Williams, and so on, they do have religious backgrounds. 𝗔𝗹𝗲𝘅 is a Buddhist.
Yeah.
And so he, deliberately brought in something that he found useful as a practicing Buddhist into psychology. But it is bringing in these sort of religious aspects, I think, other things through the back door. Now, don't get me wrong. I think, religion can be a very useful thing, but I say that as an atheist. And I say that, having written a book on atheism as well. So I'm quite upfront about my own personal views, that I became an atheist having been brought up as a Catholic. And so having, sort of shaken off religious beliefs, it makes me slightly anxious to see practices like mindfulness coming in, which may bring in some additional religious type beliefs as well, which I think some of the practitioners do bring those in.
Okay.
So I'm sort of cautiously in favor of it, but I prefer almost to call it something neutral, like attention control training or something, which doesn't sound like anything religious at all. It sounds like a bit of cognitive psychology. You know what I mean? And it has that nice neutral, that there isn't a guru somewhere in Tibet who says, hey, I invented that 2,000 years ago.
Yes, exactly. Well, we've talked that you've written the book Cognition and Emotion with your colleague Tim, and also the emotion-focused cognitive therapy one. And we've talked that most approaches, in your view, to psychotherapy do lack a solid emotion theory. Now, I have a little research question here, because we would imagine that some therapy approaches would have a more accurate emotion theory than others. But for all we know from the research, all therapy approaches have proven to be equally effective. So what do you think this means? Is a good emotion theory simply not enough to produce better outcomes in therapy?
Well, first of all, I'd argue with you that all therapy approaches are equally effective, in that for different clients with different problems, you will get some variations in the effectiveness of therapy. And I think therapists who work with more than one approach will know from their own sort of integrative or eclectic practice that they will vary the type of practice that they're doing according to what's working or not working with the client. And I'll give you an example from working in the trauma service that I worked in Edinburgh, where, with PTSD, the standard sort of practice would be to use exposure-based techniques or rewind and replay techniques, where someone, goes over the narrative of whatever the traumatic incident was that they experienced. Well, using our SPARS model, we realize that PTSD isn't necessarily just an anxiety-based disorder accompanied by avoidance. There are some types of PTSD that may be anger-based or sadness-based or disgust-based, and maybe in those cases the guidelines saying use exposure therapy with PTSD might actually make people worse rather than better. And in my discussion with all the clinicians working in the trauma service, they revealed to me exactly this sort of experience that we start off because it's normal guidelines that we use exposure-based therapy with all our PTSD cases. But we find, for example, with veterans coming in with an anger-based PTSD, that it makes them worse. So we switch away from, the exposure-based into more cognitive type of work, looking at the issues and that made them angry, like they were fighting in a war that they thought was unjust and they didn't want to be there, and they feel angry, with Tony Blair for sending them there. And that's the real cause of the PTSD, That's a very different way of working. So I think one has to be careful about the, everybody has won and all should have prizes approach in psychotherapy, because what you're talking about there are group statistics. And if you average things out, things look like they're all very much the same. But when you actually come down to the individual client in front of you, you'll find that some things may work better than others.
Yeah.
I think that's a sort of important tension in the clinical work that we do, that we shouldn't just, trot out these guideline-based interventions because 75% of people get better, say with exposure-based treatment for PTSD. Yeah. It's, well, what about the other 25%? What about the person in front of you? What's not working there, and how do you change it, and so on. So our clinical experience of working with PTSD, both 𝗔𝗹𝗲𝘅𝗍𝗂𝘁's and my own, suggested that one needed sometimes to work in different ways, with PTSD. So it's just to give you that example, to say be careful of group averages and group statistics. But I do therapies differ in their effectiveness for different people at different times and so on. And different therapists, of course.
and picking up on that, I would be interested to know your take on something that I wouldn't know if you also consider some group statistics phenomena, which is the Supershrinks. Have you've read about this probably?
Yes, sure.
Yeah, and well, it seems that some therapists seem to have hugely better outcomes than the rest of us. And it seems that the research would say it's independent of the theoretical orientation or the years of experience. What is your take on that?
Well, first of all, I think you have to deconstruct that statement. And sometimes, the super shrink can be someone who's working in an elite research clinic with highly selected patients coming through. So, not to use anyone's name, but if, for example, David Clarke in Oxford has very carefully selected pure panic patients, which none of the rest of us see, right? And we all see people with multiple comorbidities and never these pure panic patients. But, David somehow gets them to come into his, research clinic in Oxford and shows that, he can cure most pure panic patients, then I'm sure he would count as a super shrink. In that sort of way. So I'm saying that if he was getting the routine cases that the rest of us get, then maybe, the magic wouldn't be quite so great in that way. So it's to add a caution really to, who it is and how they're working and how they're performing, and if they're in these highly selective, research type establishments, which have huge funding, to promote certain approaches in that way. So I think that's one caution. Now, in everyday life, I think therapists vary in their effectiveness as well. But again, therapists tend to shift towards working with the types of clients that they're more comfortable with, more confident with. You know, so one person likes working with adolescents, another person likes working with, you know, depressed older adults and so on. And again, I think we probably adjust who our preferred client group is, partly according to our confidence and to sort of, you know, where we feel we work optimally with people. So I think one has to be cautious about, you know, the so-called super shrinks and how they may be misrepresenting, or let's say presenting us with bias data. But that's not to take away from the fact that I do think, you know, some therapists, you know, can be more effective than others. But as I say, I think therapists learn who they are more effective with and who they are less effective with, and therefore steer themselves into the groups that they feel more effective with, which is very important.
So we are just about out of time, but still I would like to ask you, to all the young psychologists beginning their career in psychotherapy, would you have some advice to give to them that you wish you had gotten when you started?
Yes, I mean, I have to say, when I started, it was clinical psychology, and I trained in the UK, was very dominated by the more behavioral approach, and that was seen as the right and the only approach. And I think it's to say that, as I've just been saying, that different approaches work with different clients and for different therapists. And I think it's that from the start for, you know, young clinicians in training to try out different models with different client groups and find out which one best fits their approach and their style of working. So it's to be prepared to try things that even you think you're going to disagree with or you're not going to like, just in case. You never know, there can be surprises, or there can be, you know, things that you can still take from even an approach that you think you're not going to like or you're not going to work with. It's just to be open in training to trying different methods and different approaches before you decide on your own preferred, you know, approach or style.
So I would imagine you'd agree with that Gordon Paul quote, what treatment for which person, at what phase, etc.
Exactly, that's right. And from which therapist, you know, it's you know, and which stage in your life you are as a therapist as well. How flexible you are, or how set you are in your ways. This is the way I do it now as a therapist as well, you know. So, but I think it's to be open to new experience and new ways of working, to try them out, I would say, to young therapists.
Mick, thank you so much for your time.
Okay, thank you so much for interviewing me. It's been a great pleasure and a great honor.